Patients can arrive at first visit with their molecular profile. What are the benefits for your, or what are these benefits for your practice? Dr. Hart?
Well, as Dr. Reeves said, one nice thing, if they come with a profile that's already there, we can screen them immediately for potential eligibility for research studies. Obviously, the studies now are not usually chemo A versus chemo B. They're for targeted treatment with or without immunotherapy, depending on their molecular alteration. So obviously, this is part of the staging of cancer now, really. I mean, it's not just the TNM, but it's the TNM and what's their molecular profile.
Yeah.
So near future, probably even staging systems will be revised to include this. And so it's very helpful when patients come with that, because obviously, as was mentioned before, if we start patients on immunotherapy that really need to be, let's say they have an EGFR mutation, and then we're going to switch them later on to an EGFR targeted treatment, we've made a mistake. We've wasted money. We've increased that patient's chance of toxicity. And there are other bad things that can happen from that. So the more focused we can be and the more that we can hit the target, we can give the right patient chemo immunotherapy, we can give the right patient just straight immunotherapy, we can give the right patient targeted treatment, it's going to be benefits overall. And as I mentioned before, once you see the patient, they're not getting treated that first day. It's going to take a few days to get, sometimes a week or two to get insurance on board. These are all, as all clinical oncologists know, they're all expensive treatments. You want to make the right decision. You want to have the information to get the third-party carrier to approve the proper treatment for the patient. That's going to take a few days also. So I love it when a patient comes with that information already when they first see me.
Thank you. Dr. Reeves?
Well, I'd just like to say it as, particularly apropos for this discussion, is that, I would be hesitant to have other non-oncologists sending tissue around for this test or that test, because tissue exhaustion is a major problem for us. But if one of the other physicians in that was seeing the patient during their diagnosis, perhaps a pulmonologist, were to order a liquid test, I think most oncologists would appreciate that, because as I said, then you've already got one step of the puzzle already figured out, at least to that extent. Now, you could still send the tissue, and that may have impacts for later, but you may not have to wait on your molecular results to plan your treatment.
Oh, thank you. That's an interesting point. Yeah, tissue, like they always say, is the issue. There's never enough tissue.
Well,
sorry.
Well, I mean, the important things. We're dealing mostly with lung cancer here today. The important things: EGFR, PD-L1, ALK, ROS. Those are going to be appearing, and with a high reliability in an untreated person presenting with their disease. So, you should be able to act on that basis without waiting for tissue.
Right. And I agree with Jim that being because the solid tumor tissue is usually very limited, we like to be good custodians of that. And, we all have our preferences as to whether we want a very large panel or a smaller panel, or which, some places will do this in-house now. At Florida Cancer Specialists now, they're starting to do some next generation sequencing in-house. And we all have our preferences to which outside lab we like to use and get the best results with. So we like to be in control of that. But I agree with Jim that, if they do come with a positive result on a liquid biopsy, that sort of will start to trump things as soon as we see the patient. Now, it doesn't happen all that often at this point, but as we move more towards everything being multidisciplinary from the start, that would be great to have that happen.
Let me add one more thing too. Many clinical trials require central review of tissue. And it's a pretty common thing to see people who otherwise appear eligible not go on study because their tissue is exhausted and they don't want to do another biopsy, which is understandable, particularly because most of these patients have just had a biopsy. So tissue exhaustion is, and I think will continue to be a problem until we may get to the day where the reliability of other methods makes it redundant. But for right now, you want to preserve that tissue and think carefully about what you're going to use it for.
Thank you. Dr. Walker?
Why, that is incredible insight and observations by Dr. Reeves and Dr. Hart. The tissue exhaustion is very, very real, and a liquid biopsy can easily overcome that. It's still a little astounding because I WebEx into the ECU thoracic tumor board every Thursday morning. And the times they don't have the molecular results, but yet everybody's talking about a treatment, let's have a treatment discussion and then a treatment decision. Certainly in breast cancer, now stage aside, nobody would make a treatment plan without knowing the ERPR status and the HER2 status. But yet in lung cancer and other cancers, we tend to want to charge ahead. And with microsatellite instability, immune therapy works great as frontline, and chemotherapy works poorly. So it's imperative to know that. So there's just so many things that you need to know before you make your first treatment decision. And as Jim said earlier, the first treatment is clearly going to be the patient's best treatment.